Good morning, everyone. My name is Erica Schendel, and I am the director of the foundation at Hudson Hospital Foundation. Thank you for joining us today on this beautiful Monday morning. We have just a few housekeeping items to review. Before we get started, we wanted to let you know that the meeting is being held in a webinar format, so all cameras and microphones have been disabled. We'd like you to enter your questions in the Q&A tool that's at the top of your screen, and at the end, we'll try to address as many questions as possible. Please do not ask any personal medical questions. At this time, I would like to introduce our speaker. Dr. Gordon Ruan trained at the Mayo Clinic and is the lead blood cancer physician at HealthPartners, where he oversees the bispecific T-cell therapy program. He also serves as a principal investigator, bringing cutting-edge clinical trials to HealthPartners and advancing innovative treatment options for patients with hematologic malignancies. As a physician, Dr. Ruan views medicine as a calling and is committed to providing the highest quality care. He believes in treating each patient as a whole person, taking the time to understand their individual backgrounds and needs. Dr. Ruan has a strong interest in clinical trials and the continued advancement of cancer therapies. While significant progress has been made in hematology and oncology, he is dedicated to further research efforts that improve and redefine the standard of care. Dr. Ruan, thank you again for being willing to share your expertise with us today. I'll now turn things over to you.
Great. Well, thank you so much for that wonderful introduction. It's an honor for me today to be able to talk with you all and share all the exciting things that we're doing here on the hematology oncology side. So let's go ahead and start with the next slide. So today, what I'll be talking with you today is a specific treatment called bispecific T-cell therapies, or BiTE. It is a type of immunotherapy, meaning that it uses our immune system to fight off cancer cells. And so it is only one type of immunotherapy, and this concept of immunotherapy came about actually back in the 19th century when there was a Dr. William Coley who had treated patients with a type of cancer called sarcoma by giving them these patients injections of actually killed bacteria called Coley's toxins to try and stimulate an immune response. And actually he showed in some of his data that some of the disease sites actually did shrink. However, at the time, chemotherapy, radiation oncology provided much more consistent responses and was just safer at that point in time. So his ideas really never came to light, but it's really been in the past 10, 15 years that our advancement and knowledge within the immune system has really grown and has allowed us to come up with so many more treatments, including these bispecific T-cell therapies that I'll be sharing with you. Next slide. So to provide a brief background on bispecific T-cell therapy. So what is this? It is a revolutionary class of treatment. And essentially here on the right-hand side, you see the image. And a picture is worth 1,000 words here. And so basically in the top green cell is called the T cell. This is our immune system cell, one of the many immune cells that exist in our body, but one of the most powerful ones. And essentially what happens is that this treatment called the BiTE, it's this very small engineered protein that the pharmaceutical companies make that help bring the T cell to the cancer cell. And the cancer cell is the red, bad guy here. And normally our T cell does do some immunosurveillance in the body, trying to see if there's any early signs of precancerous things, especially in the skin. It's been well researched in this area that the T cells can fight off and help detect early kind of precancerous or skin cancers and kind of knock them out. But this particular treatment is trying to leverage that and identify the T cell by pulling out one of the receptors and latching it onto the cancer cell, so it redirects our T cells to attack the bad cancer guys. There's two phases of treatments with this. There's a step-up dose because we have to get patients used to the therapy. The side effects from this are unique and can cause quite significant issues if we do not do a step-up dose phase where we give very small doses and we gradually ramp up. And then eventually we get to a maintenance phase. Historically, the step-up phase had to be done in the hospital setting because of the unique side effects, which included cytokine release syndrome and this neurotoxicity that we call immune effector cell associated neurotoxicity syndrome. Next slide. And so before I go more into some of the details there, I do want to also provide a timeline on how much growth has occurred in the bispecific antibody therapy kind of era in oncology. So you can see here in 2014, we had our very first one called blinatumomab. And then really since then, it's significantly evolved. And in 2025, we had linvoseltamab come onto the stage. Next slide. And here's a table that really illustrates and shows all the different available treatments we have that we can use in the clinic. There are a lot more that are being researched as well in clinical trials. But you can see here under multiple myeloma, blood cancer, we have 4 types. Diffuse large B-cell lymphoma, we have 2. Follicular lymphoma, we have 2. B-cell lymphoblastic leukemia, there's 1. For small cell, there's one called tarlatamab, and then there's one for uveal melanoma. Here's the mechanism of how these work. So you can see that each of them attaches or has this CD3 involvement. That's a T cell. And then this other side on the right-hand side is the tumor receptor that the bispecific is hitting. And so for depending on the cancer type, the tumor receptor will be different. And then here's the different routes of administration. So some are sub-Q, some are intravenous. All right, next slide. And so to dive more into those unique side effects, this is where historically these bispecific T cell therapies, it did have, it took a while before we could adapt this more routinely in a community-based setting. And this is because there are these rare or unique issues called cytokine release syndrome and neurologic issues that can occur. Fever is the most common presenting symptom, and patients are at the highest risk of developing these complications 24 to 48 hours after each step-up dose. What happens is when we give these medications, when the T cell attacks the cancer cell, there's all this inflammation that occurs and all these release of proteins called cytokines, chemokines, and that's what results in all these shifts that are occurring in the patient's body. And so when it happens all at once, it's the body needs some time to get used to it, and it gets a little bit easier with each treatment dose. But there are some very serious issues that can happen. And so there could be again fevers, fatigue, headache, cough. There could be low blood pressure, rapid heartbeat, difficulty breathing. There could be hallucinations, very rarely seizures. And so this is where historically, because of some of these potentially life-threatening side effects, this was typically given at an academic setting. However, as time has gone on, we have been able to better sort out and adapt and be able to give this safely in a community-based setting. And so before, patients were hospitalized for 24 to 48 hours. That was typically recommended and still is a recommendation for certain patients. But patients who have access to caregivers now these days may be candidates to be monitored at home, especially if they're being treated at a health system that has expertise and the appropriate monitoring equipment for the patient to take home. And so once a patient completes the step-up dosing, it's very rare to develop these rare side effects. The way to think about it is the patient's gotten used to all the shifts that are occurring in the body. the T cells are knocking down the cancer burden, all those cytokines, chemokines that the patient was exposed to. They're now adjusted and kind of adapted to it. All right, next slide. So here's an example with one of the medications called tarlatamab. So this is a medication that's used to treat small cell lung cancer. And what we can see here is for step-up dose number 1, we give a small dose of 1 milligram, and this occurs on the day 1, the first day of treatment. The likelihood of someone developing a cytokine release syndrome is 40%. Very rare that they would develop a life-threatening CRS, which is in this orange-red color here, which is 1%. For the neurotoxicity or the ICANS, it's quite rare. It's 1%. And you can see that once they get through this step-up dose number 1, for all subsequent treatments, the risk of the reaction happening is much less. So we can see it drops to 28% for the second dose. And then once they get into maintenance dosing, which is the third treatment onwards, it's below 10%. And it's quickly, it gets to below 5%. Essentially, it's non-existent. And so the hardest part for these treatments are usually the first dose, and typically the first 2 to 4 weeks. Once patients can get through that initial phase, actually these medications are usually very well tolerated. They're not chemotherapies. They're using the immune system to fight the cancer cells, and so patients, don't get hair loss. They usually don't have severe nausea, GI upset, or loss of appetite. Again, very well tolerated. Some of the other issues that tend to crop up down the road are more infection-related issues, just because the T cells are being redirected to attack the cancer cells. All right, next slide. And so here's another example with another bispecific T cell therapy, where we can see for mosunetuzumab, this is used to treat patients with follicular lymphoma, also has an indication for large cell lymphoma. And this particular bispecific has a lot lower risk of complications. So you can see here it's actually, instead of 40%, it's 19%. And then the grade, the higher risk, more life-threatening side effects is about probably like less than 5% here too, similar to the previous agent. And you can see the first dose here is a little bit different as well. So each of the bites or bispecifics have different dosages. So this one's 5 milligram for the first dose, and then it goes to 45 milligram, and then it stays at 45 milligram onwards. And you can see again the risk of that cytokine release syndrome, that inflammatory mediator response, significantly drops as each dose goes on, and it's essentially 0% once patients get into the fourth treatment and onwards. All right, next slide. And so for our Health Partners group to be able to provide for safe and effective delivery across our health system, our main mission for these therapies is to be a center that allows us to effectively offer these treatments to our patients and optimize patient safety and experience. Like I mentioned before, historically it was academic centers that could we're the only ones who felt more comfortable administering this. But as the years have gone by, we have seen, other community centers take on administering these treatments so patients can stay close to home, be local. And for us, we actually launched our program last year, and it's been really effective. And so, as part of our bispecific T cell therapy team, it's myself as the director of the program. Our backup physicians include our chair, Dr. Daniel Anderson, and one of our research leaders, Dr. Yen Ji. We have pharmacists who play a critical role, our advanced practitioners, and then my lead clinical nurses, Treya Schmidt, as well as Michaela Levine, have been really instrumental in being able to carry this through. And our program not only depends on just coordination within our own department of HEMONC, but also the emergency department, as well as pharmacy, other nursing staff, and then the inpatient services as well. All right, next slide. So what does our program include? What is it that allows us, what sets us apart? that allows us to be able to give these medications now safely to our community patients and not have to refer them out to one of our academic centers. So one is, our program has experience with all of the current FDA-approved bispecific T-cell therapy. So before we launched our outpatient program, we did have a period where we were doing the treatments in the hospital, just making sure that as a group we got comfortable and used to these therapies. We also have it right now so that for the step-up dosing, they're only occurring at our main flagship sites, which would be Regions Hospital on the east side, as well as Franchu Cancer Center in St. Louis Park on the west side. And then we are slowly working towards, uh, getting access to other sites, but right now step-up dosing still do occur at these two main sites. But maintenance dosing, so once the high risk period is done, we are able to do this outside of Regions in Franchu. And so being able to reach out to patients out in Maple Grove, Burnsville, Coon Rapids, Lakeview, Hudson, New Richmond, and we're continuing to aim to expand that as these therapies continue to increase in utilization. So as part of our innovative treatment planning, um, again, many of the community centers historically have had patients get step-up dosing in the hospital or at an academic center. For us, all our patients are very carefully monitored by our bispecific therapy team to be determined if the patient can get this outpatient. A 24/7 caregiver is required. There's also extensive education that occurs with a 60-minute, nursing ed visit with a patient caregiver. We give out, symptom monitoring equipment, blood pressure cuff, pulse oximeter, oral thermometer, patient education handout, and wallet card, and then instructions on if when able, to um, call for help or escalate to go to emergency department if issues arise at home. The symptom monitoring equipment is incredibly important, and that's where it was actually not possible to do this without support from the foundation because for us to get these supplies, we had needed funding for that, and I'll talk a little bit more about that later. But that was a very critical piece to be able to do this safely and to be able to allow this therapy to be given outpatient out of the hospital in the comfort of the patient's home. All right, next slide. And so here's an example of the patient education handout that we give. So using one of the treatments I showed earlier with tarlatamab, you can see here that uh, it's essentially a printout that details all the different, what ifs and how to, manage your medications, how to do the, vital assessments. And our nurses go over this patient education handout at that nursing ed visit. Next slide. Here's just another portion of the patient education handout continued. Um, again, showing providing text on what to do if you need medical help. We give a tracking form. One of the nice things with the tracking form is by making patients kind of write it down with the old school, just pen and paper, allows for the caregiver and patient to really get used to this. And so when we give the treatment doses at our infusion site, we have our infusion nurses also work with the patients and caregiver to make sure that they understand this part so that when they return home, that they'll be, well equipped and confident and know how to manage issues if they occur. Next slide. And so here's an example of a wallet card that we give patients because here in the Twin Cities, there's multiple health systems. In case, a patient goes to a non-HealthPartners emergency department, then they'll be able to take this wallet card with them, show it to the emergency medical providers so that they're aware of what treatment the patient is on and to get in touch with hematology oncology as soon as possible. All right, next slide. And so here's one of the kind of research QI things that I've been working on with one of my fellows, which is that we're trying to study with this program. We have this approach in place where we can allow for patients after they get the treatment at the infusion center, they can go back home. They don't have to be admitted to the hospital. But is it really saving time, outside of the hospital? Because, like I share with you, there is risk that patients could develop a side effect where they would have to seek help, right? Um, and so this is data that we've taken from our group of patients, and this was presented at one of the regional conferences in Minnesota, where one of the figures that I'm sharing here for tarlatamab, you can see that for patients who got the step-up dosing, that's what SUD stands for. So for step-up dosing inpatient, the average hospital stay actually was a total of 6.5 days. And part of that is because every time we admit the patient, they have to stay for tarlatamab a minimum of, um, you know, 24 hours. During that 24 hours, they're not comfortable in the hospital. What if, like, you know, they didn't get a good night's sleep, and then now they're answering the questions for some of our cognitive assessments incorrectly, then we keep them for another 24 hours, and then sometimes it gets confusing because we have to sort out between, is it because of poor sleep in the hospital, or is it because of really a side effect of the medication? And so what we've noticed, and this is actually shown in other published community-based data, that for patients who get treatments outpatient, actually the documented side effect incidence tends to be a little bit lower compared to if patients are being treated inpatient. And again, could it be because of, if a nurse keeps checking your blood pressure and your temperature, if it happens to just be slightly off, then we call that as abnormal even though the patient feels fine, and then again we delay the hospital stay for that. And so for the outpatient stay, you can see that the average day spent was actually just 1.25, or I guess 1 to 2 days in the hospital if we rounded completely up, but significantly lower compared to the average stay inpatient. Next slide. So for research, our group is involved in multiple cancer clinical trial research studies that are studying bispecific T cell therapies in small cell cancer, prostate cancer, multiple myeloma, and we also have a phase 1 clinical trial. We're looking to continue to get more to our center. All right, next slide. And then for future directions and goals, we want to expand the step-up dosing. We want to continue to be able to do this actually at other sites too. And so we're looking at some of our Western Wisconsin sites to see if they would be feasible areas that we could do step-up dosing so that patients don't have to actually come all the way down to regions. Depending on where they live quite far out in Wisconsin. It could be an hour drive to Regents, but much closer to, let's say, New Richmond or Lakeview. And so that's something that we're exploring. We want to be able to introduce maintenance dosing to all of our sites. Still, we don't have access for maintenance dosing to some of the even more rural sites, but we're working on that piece. And then we want to continue to increase our access to clinical trials, and then continue to keep up with the pace of the innovation with the improvement in the access, safety, and patient experience. Next slide.
Okay, thank you, Dr. Ruan, so much for that information. That was really informative and very fascinating. Before we head into the Q&A, and we have a lot of questions coming in, we're going to turn it over to Pete McNabb, who is one of our foundation team members. He's going to talk a little bit about the impact of philanthropy in this work.
Good morning, everybody, and thank you, Erica, for monitoring today, and thank you again for Dr. Ruan for your presentation. You already heard a little bit about what the foundations have done in partnership with our providers who are now offering bispecific treatment, but I just wanted to get a little more specific as to what some of the items that are included in the support that we're providing are. So as was mentioned earlier, the possibility of providing and monitoring patients who are receiving bispecific therapy and doing follow-up in an outpatient setting is looking increasingly preferable. But in order to make that possible, we have to make sure that the caregivers or the support system that our patients have in the outpatient setting are equipped with the necessary equipment that they need to monitor their loved ones and to make sure that all the vitals are at the necessary places and that the doses are being tolerated the way that our providers are looking and wanting for. And so why is this necessary for the foundations to step in? Well, in many instances, I believe that the home monitoring, medical equipment that is needed to take this treatment safely is not right now available through insurance reimbursement. So this is another place, a kind of a hallmark of our work, a pillar of patient special needs where we can be helpful and impactful. And right now that looks like offering things like Omron, blood pressure monitors, pulse oximeters, and oral thermometers, blood pressure cuffs, these items that the home caregivers can use to monitor patients who are receiving treatment and to make sure that all the vitals are where they're wanting to be and that things are going safely. So this again is kind of part and parcel with a lot of what the foundation does. We're particularly excited though about being able to be involved in bispecific therapy, just because not only does it check the box of patient special needs, but it also contributes to our interest and desire to support the innovations that are taking place across our health systems and especially in oncology. So really wonderful work and just great to be able to hear more about it today from Dr. Ruan. So hopefully this continues to be a safe and effective modality. I can move on to the next slide. So as Dr. Ruan mentioned, the kind of the bulk of this work with bispecific therapy is taking place at Regions and Methodist right now. And so that's where foundation support is going for the kind of take-home monitoring bags. But oncology work continues to take place at all of our hospitals across the system. And we have patients in many different geographies. And so we want to take a moment to shout out and highlight the work that Hutchinson Health Foundation has done and continues to do for their oncology patients in that region. So Stroll for Hope is an annual event that brings together survivors, caregivers, and community members to raise funds for those local patients who are receiving cancer care in the McLeod County. The great thing about this event too, especially the way Hutchinson Health talks about it, and you can see on their webpage that not only do they include kind of a call to folks to show up and be a part of this event and support their local neighbors and oncology patients, but Hutch is really great about making the opportunity for support just as obvious as the opportunity to support. So, going to the Hutchinson Health Foundation homepage, you'll see not only information about the event, which is upcoming if you're interested on August 7th, 2026. There's also the forms and the access for the patients themselves to receive, again, patient special needs support for all those aspects of our lives that can be affected and put under duress and strain when we are going through, transformative and life-altering care like oncology treatment. So really excited about this event. Again, it's upcoming August 7th, mark your calendar. And if you are a patient in this geography, please look into the support that is available to you through Hutch Health Stroll for Hope. So thanks so much, Erica and Dr. Ruan, for giving me a chance to chat a little bit about our work, and I will sign off for your questions. Thank you.
Yeah, Thank you, Pete, and thank you again, Dr. Ruan. Just a reminder, you can put questions in the Q&A at the top of your screen there. We've had a few questions coming in, so we'll start with someone commented how this seems really innovative, and they're wondering, are there other health systems in our geography who are providing this treatment, or are we really kind of on the edge of the early edge of things?
Absolutely. Thank you for your question. So right now, certainly Mayo and the University of Minnesota offering these treatments. Within the community health system, most of the other sites are still doing it with inpatient step-up dosing, so they can offer it, but they would be requiring all their patients to get hospitalized for the treatment. So I can't speak to exactly how each health system is doing it, but I believe, Alina, for example, North Memorial kind of follow more of an inpatient step-up dosing protocol. I believe Minnesota Oncology is starting to do these treatments with outpatient step-up dosing as well, following a similar model of having, someone with the patient 24/7 as a 24/7 caregiver, and then also being able to provide the blood pressure cuff, the pulse oximetry, and thermometer, and other necessary take-home materials.
Okay. Thank you. And the next question is, I think this is referring to the nursing education that goes along with the program. What is the definition of a caregiver when you're providing education to the patient and that caregiver? Who are you seeing receive that?
Yeah, so typically the vast majority of patients will have their, partner or their like a child be the uh, caregiver. So like they're, for example, if it's a 70-year-old gentleman, he has, 3 kids, the 50-year-old son would be a part and, designate himself as the uh, caregiver. And then so what's important is whoever is going to be the 24/7 caregiver, we do require that they receive the education. There are situations where we've had people alternate, and so it doesn't necessarily have to be just one person the entire time. One thing I should also specify here is usually the 24/7 caregiver needs only need to take place during a 24 to 48-hour period after each treatment dose, and usually the treatment doses are you know split apart by like on once a week. And so for example, if someone got a treatment Monday, if they're needing only 24-hour caregiver to stay with them, they would say, let's say their partner or their son or daughter, who would be the designated person, would stay with them from Monday to Tuesday, and then that person could, doesn't have to be a 24/7 caregiver throughout the rest of the week. And so it can switch. It doesn't have to be exactly one person, but every person who's chosen to be that caregiver does need to go through education, does need to commit to being with the patient 24/7 during the designated time periods. And the main reason for that is because if the patient runs into issues, for example, confusion is a rare side effect that could occur. The patient will not be able to advocate for themselves. Patients certainly could advocate for themselves if they develop the fever, but if the confusion happened, then we do need that other person to be able to assist the patient to seek medical help.
Okay, thank you. That makes sense. Next question is, are immunosuppressant medications required?
Yeah, good question. So the if the patient develops a side effect, for example, fever or confusion during the step-up dosing phase, those side effects are caused by the inflammation. And then in that situation, we do use agents to calm down the inflammation. The backbone is dexamethasone, which is a steroid. But in certain situations, we also need to use an agent called tocilizumab, which would be considered an immunosuppressant. Typically, this is just one-time dose that needs to be given. And then once the patient, again, completes the step-up dosing phase, then they're out of that high-risk period. Once patients are in the maintenance dosing phase, they do not usually need to be on any immunosuppressants. Actually, instead they are typically on supportive care agents to help prevent infections, because the bispecific T cell therapy itself, in certain extents, one way to think of it is it redirects the T cells of the immune system to attack the cancer center. So the immune system does get a bit distracted when it comes to fighting off infections. And so in some ways, one could view, a bispecific T cell therapy to somewhat, affect the immune system so it's not working as well against infections. And so in that step-up dosing phase, yes, we may need to use immunosuppressants, but only if patients develop side effects. Once patients are in the maintenance dosing phase, they do not need to be on, additional immunosuppressants. Actually, we use agents to boost their immune system.
Okay, keep the questions coming. There's lots of good questions here. I think a lot of people think of chemotherapy as a first line of treatment for cancer. So what are the benefits of this treatment over chemotherapy?
Yeah, actually, the main advantage of this particular treatment, these class of treatments, are on the whole, the side effects, generally speaking, are more tolerable. So when we think of chemotherapy agents, we usually think that for most chemo agents, there's a cumulative amount that a particular patient can have. So, I'll give an example. One is like anthracycline is a type of chemo where we can only give so much, because once we hit a max dose, then patients will have life-threatening, complications. And so, with these immunotherapy agents, we are not seeing that there is a cumulative dose. And so we can keep giving these treatments as long as the patient is responding well and not having life-threatening, infections, because their immune system's getting distracted, attacking the cancer cells instead of fighting off infections. So for these immunotherapies, bispecifics included, they're often very, very well tolerated, and we can keep these patients on these therapies often for a lot longer compared to traditional chemotherapy agents. And actually, for that reason, these treatments are moving more and more into the earlier line setting. So we don't have any that are consistently being used in the first line setting. There's a few exceptions there, but I believe in the next 2 or 3 years that all these bispecific T cell therapies will probably be in the first line setting, and they will either be replacing chemotherapy or being used in combination with chemotherapy, but then the chemo later kind of tailors off once the appropriate response is achieved. So again, these treatments are, in my opinion, a lot more better tolerated on the whole, and then will be in the first line setting, and it will be immunotherapy will be usually the go-to treatments that we're going to be using. For patients who don't have access to bispecifics or immune checkpoint inhibitors, which is a different class of immunotherapies, then chemotherapy is still typically the go-to for those cancer types.
Okay. And that was a question that just came in. You highlighted specific cancers that this is targeted for. Are there additional cancers where this therapy can be applied at this point?
Yeah, so right now we see a lot of the application in blood-related disorders. The reason for that is because one of the reasons these treatments work is we find a target on the cancer cell. Cancer cells often share some similarities with our, other normal cells, and so we have to be very careful when we target that specific cell type, that if we were to, have to kind of wipe out that entire cell type, that the patient could still, not have life-threatening side effects. And so for blood cancers, patients actually can live without their B cells or without their plasma cells. For patients with, let's say, lung cancer, you have to make sure that the immune cell does not attack the normal healthy lung tissue, because we would not be able to live without our lungs, right? And so that's one of the limitations right now when it comes to solid tumor cancers like prostate, other, lung cancer types outside of small cell colon cancer is being able to find a safe target. The reason we can target small cell lung cancer is because small cell lung cancer expresses a unique target that is not found on normal healthy tissue. And so when we target that, the patient does not have life-threatening side effects from organ damage from that.
Well, we have more questions in there than we can probably tackle in the last couple minutes here, but we'll do one more. Generally speaking, what kind of feedback are you getting from patients who are going through this? Is it having an impact on their overall care experience?
Yeah, absolutely. I have had lots of wonderful feedback from patients. These treatments are revolutionary. They're allowing patients to live longer and better. One example is I had a patient with relapsed refractory myeloma. If these treatments were not available, there would be nothing else left to offer. He was not strong enough to tolerate or have us reuse chemotherapy. Thankfully, I had one of these bispecifics I could provide for him, and he's still around today. If he had the relapse disease last year, and if I didn't have these treatments available, that would have been it, for him. And so he's still around. He's still doing very well. He was able to see his nephew get married, and that was such a huge, important milestone for his life. And yeah, he continues to do really well. So again, these are life-saving treatments, very powerful, very effective, very safe if used appropriately. And I believe that these will be first-line treatments in the near future.
Thank you. Thank you, Dr. Ruan, for the information, for your passion and the care that you provide to our patients. As someone put in the chat, we're grateful for our oncology teams and what they do for our patients. And thank you, Pete, also for highlighting the impact that philanthropy has on this work. We appreciate everyone joining us today. Please keep an eye on your email. We will send a recording out of the session in the coming days so you can review and learn more. And the couple questions we didn't get to, we'll work on getting those to Dr. Ruan, and hopefully we could get answers to folks on those. So thank you again for joining. We appreciate everyone. Have a wonderful day.
Thank you all.